Assalamu alaikum. Namaskar. Good morning to you all. It's indeed a pleasure to be amongst you all. I must say, I could give this whole in Bengali as well. আমি এত বাংলা বলতে পারি কি আপনার সঙ্গে আমার কথা তো বাঙালিই হয়ে যাবে বাট বাংলায় হয়ে যাবে বাট সায়েন্টিফিক কন্টেন্ট আমি বলতে পারবো না এই জন্যে লেট মি জাস্ট নাও বি মোর ফ্লুয়েন্ট ইন স্পিকিং ইন ইংলিশ a foreign language for all of us, but at least it conveys the method. I'm here to give you some inspirational messages, not to relate to you my 35-year journey, but to see how I formatted myself and got to this level, and how can I expect you to do that. 35 years since I returned to India from England. And I'm just going to present a very brief, not about my journey, but only 5-6 slides around what you can understand. So this was me when I returned from England at the age of 34, having spent 10 years abroad and done my training, and also I was doing extremely well. And irrespective of what anybody would say, it's not just for the return, for the love of the country. I had my responsibilities towards the family. And my mother wasn't keeping good health. My parents did not want to move. I was the only son, as happens in many of our families. And in a way, I was forced to return back, even though clearly my wife didn't want to come back, and I also didn't want to return back to the country. When I came back, there was only one intent. The one intent was because I have come for my mother, not necessarily for my motherland, but for my mother, I will never go back, because anyway, we get fed up in 2 years after coming back to our country and say, abroad is so good, why am I here? I have all the opportunities open to me in UK and in United States. But because it was for my mother, you never give up that. You do the best you can. And the first time I said, in 1989, I said, nobody from India should ever go abroad for any advanced procedure in cardiac intervention. That is what I said. Because people were going across for angiograms and bypass surgeries and angioplasties abroad. I said they will never go. And in 1997, I decided, after I had trained the first Bangladesh fellow from Bangladesh in interventional cardiology, and the second one came, the first was Momennu Zaman, second was Rayan Anis, third was Sorabu Zaman. By that time, I had decided, I will make sure that nobody from Bangladesh ever has to travel abroad for any treatment. And I've stood by this today till today, that I've never come here to do a workshop in any private hospital. I will only do workshops in government hospitals and National Heart Foundation. I did that, because nobody from Bangladesh should travel abroad. And I therefore thank you all for having created, and one of my great esteemed trainees, in fact, all around, are the great esteemed trainees who revolutionized interventional cardiology in Bangladesh across the world. And that's what I'm proud of. So if I stand here today with a pride, it's because I see them around and you see them around. So it's not Ashok Seth. It is them who actually make me far more proud than I can make you proud. So let me take you through this journey. Young boy, I think I probably look smarter than that time. But I wasn't bad. I looked good. October 88, and when I returned back. And you know, I modeled myself. I believed that I could do anything. I had the expertise. I had the skills, but I said, I have to prove that my skills are greater than anybody else in the world. I followed my story from, there's an interventional cardiologist by the name of Jeffrey Hartzler in Kansas City in the United States. I went to watch him in balloon angioplasty days. And I'm taking you back, balloon angioplasty. Balloon angioplasty, there was no stents. There was a 5% chance of needing emergency bypass surgery while doing angioplasties. The theater would be standing by, the cardiac surgeon would be breathing down your neck, saying, why are you doing this ruthless, unproven, crude technique on your patients? Because your patients can die. Because actually, there would be 2% patients who would die 5% would have emergency bypass closure. There would be 10% rates of myocardial infarction. And we didn't have antiplatelet therapy apart from aspirin and dextran and persantin were our antiplatelet therapy. We had no imaging, we had crude toys. And when we blew up balloons inside the artery dissected. And it dissected, there was nothing to stop that dissection apart from pray. And we prayed heavily in those days to save our patients' lives. Well, in those days, you therefore needed conviction to take a strategy forward with such conviction because surgery was the gold standard and we as interventional cardiologists were literally playing with toys. Now, when you see this case right in front of you in 92, at the age of 37 when I was revolutionizing the world, this case is right coronary artery long, at least a 40 millimeter long stenosis, anomalous left main arising from the right coronary sinus with an ostial LED stenosis and 3 other lesions, long lesions, right down to the OM2 from the proximal circumflex. Even in the days of stents and the best drug-eluting stents, even in the days of best antiplatelet therapy and imaging, we would be actually scared to take up a case and we would perhaps think it's unethical to do such. Well, I'm talking about balloon angioplasty days. When I took up this case in balloon angioplasty, I treated at the same sitting with balloon only all this, including the ostial LED, including all that circumflex. Now, I just take you forward to that this is the post result for that circumflex from the ostial LED. Here's the blowing up the balloon in the ostial LED into the left main. You're talking about 30 years ago. You would not dare to do it with stents in the present era. This was the result subsequently at the 2 years follow-up. Now, I want to take you through this humorous fact of life. You got to have conviction. When I actually sent this case for publication, 4 journals not just refused it, actually said that we believe as an interventional cardiologist, it is unethical for us to publish this case because it sets a bad example for interventional cardiology to do such cases. We have to be doing single proximal discrete stenosis till angioplasty gets established as a therapy. And yet Jeffrey Hartzler in the United States would treat lesions like this. And I said, okay. So 2 years later, when the patient came with chest pain and I did an angiogram and all these blocks, all these lesions had disappeared and the artery was looking good and there were no lesions there. 7 lesions treated, including the long RC and the ostial LED. Patient was doing well. I have sent this case for publication and they finally accepted it. And you know the comment which came, and this was from a 5th journal because I didn't want to send it to those 4 journals. The 5th journal writes, "We commend you for such exciting case from balloon angioplasty. It shows how balloon angioplasty can actually work and the direction for balloon angioplasty is great." Those were the differences we faced as Asians because the West was not ready to take leadership from Asia at that time. And if you see what it says here, it says the angiographically document follow-up for 2 years, the patient remains well. This case represents the only such report in the literature, only such report in the literature. Now, the transfer of leadership from West to East happened with a lot of efforts. In the days of cutters, drillers, scrapers, and burners, which was 92 to 95, and we're talking about the pre-stent era, where we didn't know how to actually keep patients, I went on to be the biggest guy in Asia Pacific to do directional atherectomy. And do you ever know what directional atherectomy was? When we blew up balloons in the coronary arteries, they would dissect, and the only way we could keep thinking was, can we have, apart from balloons, can we have some devices? Can we cut out these blockages from within coronary arteries and remove them completely? And that was the directional atherocath. Very few people in India ever mastered it. Very few people in Europe, in Asia mastered it. And I actually used this device. But you know how you have to take frontiers forward, and I'm therefore making you think. Directional atherocath was only being used in a few centers in the United States. Was the future, because it could cut out plaques from within the coronary artery. See this ostial? We talk about how to do ostial LADs with stents this time. This was a magic tool, a 10 French guiding catheter, a cutter, which actually was cutting plaques from within the coronary arteries, rotating at 2000, cutting into a housing, and you can actually see this cutter moving backwards and forwards from the ostia. And here it is, the plaque just falls into the ostia and you cut it. And you circumferentially cut it, and as you cut it, lo and behold, look at the final result. That's what you have. You actually cut out plaque from within the coronary arteries. You restore, and you know what you cut out? You cut out these strips from within coronary arteries. When I actually started this technique, it wasn't available in Asia Pacific. Now look at how the drive has to be. I went to a center in the United States. They did 4 cases that week and I watched it. They threw every device into the dustbin. I picked it out of the dustbin. The guiding catheter, which is transferred, the motor, the cutter, and I brought them in my suitcase to India. And I then sterilized all those. The 2, at 4 motors, the 2 actually ran out. They were click-click type motors. They actually started working in the suitcase. They made zzz noise, and they actually ran out. 2 motors function. I was able to do 5 cases by that re-sterilized stuff. I had already done 25 cases by the time this device ever got introduced into Asia. I'd done 35 cases by the time it got introduced into India. But I had made angioplasty safer for the patients who had these eccentric, huge plaques in large arteries and cut it out. So you have to push boundaries. I was pushing boundaries with the devices of rotational atherectomy because even before the days, do you know that 28 years ago I was doing 250 rotational atherectomies per year? Those were the pre-stent eras. And I created the first course of rotablator use outside the United States, and I trained 30 cardiologists in Asia Pacific to use rotablator in 1994. And if you think that Malaysia got trained by rotational atherectomy in me, Philippines got trained by me, even Australia got trained by me in rotational atherectomy in the late 90s, it revolutionizes everything. So why was this path there? And I won't take you through any of this because the first ever implant of a valve was done with us with the self-expandable core valve was 2004 with me in India as a part of the first in-human study. That was the first ever in the world. And when you actually take it through this, and it was the first in a patient with AR, which got acknowledged in the London Wall of Fame. If you see, TAVI, first successful core valve implant in the world in a patient with AR was with us. And the Impella, the one you hear of now, being the gold standard of mechanical circulatory support in the United States, the first ever live transmission to the main arena of the TCT in 2007, even before Americans had started using it, and it was only used in Germany, was from Ashok Seth from India, transmitting to the main arena, telling United States how to use Impella as a mechanical circulatory support. That is 16 years ago. So how do I actually get to this level? How do I get to this level? So there are 5. So I'm going to tell you as an interventional cardiologist and then as a doctor. It's been an astounding journey. I mean, I could relate to you 15 other techniques and technologies that I was pioneered, not just for Asia, but and led across the world. But you get it firstly from a belief in yourself firstly. You have to believe in yourself. You have to believe that you've actually been destined. You can't be proud of it. You can never be proud of your hands. You are destined to serve people, and perhaps He's given you the expertise for the benefit of the people. I'll just give you an example why I say this, that it's not you yourself that you're going to be proud of. And this talk will be inbuilt some messages to you. For example, if I was going to be proud of my expertise and skills and what I can do, then I perhaps will be going out of this door, sitting in a car where the driver will bang the car door on my hand, and my hand would be fractured. I would never be able to hold anything again, and the greatness of Dr. Seth's skills would be gone in a split second. So if that can disappear, I could walk down this stairs and slip and hurt my head and have a bleed in the brain to be in a coma for the next 2 years, and the greatness of Dr. Seth would be gone in a second. So aren't you destined that you are in a profession where every day you get du'aएं from everybody you treat? Now, which is a profession in life where people get so many blessings from everybody that they treat, from everybody, just as a part of your routine work. You treat somebody with antibiotics, you walk away, the guy gets better, he says, you saved my life. Which profession? So we are privileged to be in a profession, and if we are privileged in a way to have had expertise, he willed it, only you can pray, give me today that every of my patient does well when I walk to the hospital, and when I come home, you just say, thank God that every of my patients got better from my hands. Because you could do the same thing and blow up the same balloon in the coronary artery, and you can have a perforation, and you'll wonder, why did I have a perforation in this case, yet in the last 200 cases I didn't have a perforation? Or you could actually have a perforation in every case, because we still deal with such crude technology, which will 10 years, what I was doing 20 years ago appears outdated. Today, isn't it? What I was doing 33 years ago, which I was proud of, what I was doing 28 years ago, which I was proud of, which I thought had conquered the world, which was the biggest advancement in science, is actually crude, outdated, and almost unethical today. And today's technology would be considered unethical and crude 30 years later. The fact our patients don't die in our hands is not because we are so good, it's just that each time God wills that through us they continue to live. So that's my first point of convey to you. The second point I want to convey to you is, there are 5 things which make us as a good doctor. I can take you through the interventional cardiology journey in just the end 5 minutes, and you can ask me any questions. But it's more important for us to understand where we are at the moment. So what do I say? There's care, there's compassion. The first 2 C's, and there are 5 C's that I will expand. We have to be always care and compassion. What do I mean by that? I mean 2 things. Care and compassion means that even at 12 o'clock at night, if a patient's relative, after you've had a hard and busy day, you are actually walking out of the cath lab and somebody, a relative says, after he goes home, what should I give him to eat? You have 2 options in life, 2 real options. You can actually either be angry and say, is this all that you can think of at 12 o'clock at night? Do you realize I've been working from 8 o'clock in the morning? I have done 22 cases. Couldn't you have asked me this yesterday? Do you think that I should be standing here? Do you think you are going to sleep at home? I'm still awake. I've not even met my whole family. What are you asking me? And the patient goes away sadly, the relative goes away sadly saying, what a doctor. And if a complication was to happen that night, the relative would be so angry at you, not because you did a bad case, but you were a bad guy. You weren't a good guy. Or, even in lesser sentences, even in lesser words, you could have told him that perhaps you should have less oil in your food, he should make sure that he eats lightly, that he doesn't eat food from outside, omit this, omit that, and he'll be fine, and I'll talk to you also more day after tomorrow. That actually took less number of words. But the patient's relative thought you were actually the best. You actually gave, and from there on he thinks you actually did the best for the patient inside, just because you actually did the right thing outside. So that's care and compassion. Make that a habit. Make that a habit never to be angry with a patient's relative, however, whatever he is. You cannot be impatient. You came into a profession for being patient. Nobody's worked as hard in their life. I've done 52 cases in a whole 24 hours. And that's not just too long ago, that's 8 years ago, where I think I finished 22 angioplasties and numerous angiograms. I was still working at 6 o'clock next morning. But even at that 6 o'clock next morning, when the patient, I came out and told the patient's relative that everything is fine, I spent time with him talking after 24 hours of work. And that has to be built in. Care, compassion, I've talked about. Commitment. Our profession is a commitment. Whether you're an interventional cardiologist, whether you're a cardiac surgeon, it's a commitment. And it's a commitment to our profession, to our patient, but it's also my commitment to the young gen. The young gen in our commitment needs to look up to me, and that will happen to you. You are my second generation of trainees. The first generation of trainees have already become great people. You see them all around you. Yesterday, there were 40 of what we call people who have mentored and trained, and they've all become great. You're now the second generation. You look up to them, they look up to me. Aspiration is an important aspect. You have to aspire, and we have to inspire you. Otherwise, it doesn't work. So we got to do everything. And that's why I say you have to have that sort of commitment that it inspires the juniors under you to say, this is the guy I will be like. They have to walk into a medical college. Do you know that for the last 30 years, everybody who's actually gone into a cardiology, and I'll say most who've gone into cardiology, the first gen always said, we want to be Dr. Seth, including the second gen still says that they still want to be Dr. Ashok Seth. Now that has to be your inculcation into when they want to be a cardiologist. They have to see you as a, so that's the commitment. And then you have to have competence. What does competence means? This is exactly what I showed you. You have to keep updated with the latest techniques and technologies. You have to be sure that your skills are trained and to such an extent that they will never harm the patient and will always do good for the patient. And if you haven't got the skills, combined with someone who has those skills, if you aren't a CTO specialist, you can't open up CTOs, doesn't matter. But if you have a friend who's a CTO specialist, make sure that he's your partner. Be happy to stop where you have limitations. Be happy to refer cases to your colleague and partner who can do a better job. Combine with them, but give the best to your patient. That competence has to revolve around upgradation of skills, upgradation of knowledge, and knowing that you're giving evidence-based practices to your patient. And finally, this last C is the most important C. It's conscience. You should be able to do everything right for the patient. The patient who sits in front of you has to be thought as your father, your mother, your brother, your sister, a relative, because there's so many gray areas in interventional cardiology. Angioplasty versus bypass surgery, angioplasty versus medical therapy, calcified lesions, unfavorable lesions, bad LVs, what is the right cause, leaking valves, combined therapies, what is the right? You can twist the trials in any manner that you like to convince the patient. I could twist the trials of TAVR in low-risk patients to suit either the surgeon or the interventional cardiologist. For TAVI versus surgical aortic valve replacement, I can do that any day. But I always look at the patient in front of me and I say, with all that knowledge that I have and all the gray zones and all the interpretation of trials, this guy who's sitting in front of me was actually excluded from those trials. Those trials never looked at the guy who was sitting in front of me. So how do I deal with him? And I say, if I was in his place, what would I have? And if I was in his place, then what would I have? And that just not goes for the treatment. It also goes for the stent you would be implanting in that patient. Which stent would I give it to him? Which route would I actually do for him? Then you actually know that you've actually taken the right decision because you would do the same thing for your own self. Do I make myself clear? Analyze this again and again in your mind. The treatment that you give to your patient has to be the same treatment you would give to your father, you would give to your mother, you would give to your sister, and give to yourself. If you're able to do that, and that's your bottom line, if you're able to tick mark that, your conscience is in the right. Because believe you me, you put a stent into a 50% lesion in a person who you knew had atypical chest pain. There is no reason for you to be able to sleep peaceful that night. There is no reason. But even the worst thing, I'll guide you, if you ever do that, and you earn 10,000 rupees, or I earned 10,000 rupees, and I went home, and I bought my family a lovely present 2 days later, how would it be if my daughter asked me, I hope that every penny that you've earned is from your own ethical earnings. And that day it'll strike me, was every penny that I earned ethical or not? I have no right to give anything to my family which has been earned beyond ethics in medical profession. Then I think I've actually failed them. whatever I think, whether I failed myself or not, with my Mercedes that I have got, I may have actually failed them because they don't need my Mercedes. They don't need any cloth of mine which was not bought from my ethical earnings. Those are important influences in our lives. If you keep these 4, 5 C's in mind, then we come to making of an interventional cardiologist the next step. The next step you say is how successful, how can I be successful? The next question will come to me is, how can I be a really successful person? What is the successes of a successful person is not that I'm driving around in these fancy cars, not that I live in a big house, not that I wear flashy clothes which are tailored. That's no success, believe you me. That is a posturing. Success actually happens from within. If I was to say that success means different things to different individuals at different times, your criteria for success as a young gen would be my next job. Your success would be, can I get can I get a better salary? Then the next success would be, can I become a better known interventional cardiologist? Your next success would be, can I have masses of patients? And as you go along and get a family, your next success would be, can my children go into a better college? Will they qualify for a better college? If they qualify, have their marks been good? Then that becomes a success. Then finally, when it comes to my life, you say, did I live a good life? Am I bonded with my family? Are my children bonded with my family? Am I bonded with my wife? Do I have memories of the past? Do I live nicely? That's a success. You actually start realizing that you're changing the definition of success every day. But to be a successful and to be a success all round, I can guide you simply. It's not the interventional cardiologist that actually you're a success. To be a good interventional cardiologist, you have to be a very good cardiologist. You have to be a very all-round cardiologist. You should be able to treat heart failure as good as a heart failure specialist. You should be able to actually treat hypertension and diabetes in every manner. Then only you're a good interventional cardiologist. Otherwise, you're doing a technician's job. And I can tell you that very clearly. You're doing a technician's job. You're not treating your patients. But then you look at it, to be an interventional cardiologist, you've got to be an extremely good physician as well. To be a cardiologist, you've got to be an extremely good physician. You need to diagnose anemia in a guy with heart failure or a guy with worsening angina, unstable angina, just by looking at him. You just can't say, I'm going to do your angiogram, and the guy is white and his hemoglobin is 6. So if you can't diagnose that, you have no right to do angiograms. So you've got to be a good physician. But to be a good physician, finally, you've got to be a good man. You've got to be a good human being. And that only what makes good physicians. So finally, we get down to this same thing. You have to be a good man, to be a good human being. So I don't want ever in my life for people to remember me saying, look at that list of achievements, look at that list of achievements. Wasn't he great? What a great, successful guy. I don't want it that way. The day I die, nobody should be talking about that he did this, he was awarded doctorates from innumerable universities, etc., etc., etc. That would actually get buried with me. The only thing which wouldn't get buried with me, hopefully, is that he was a good man. He was a good doctor. And if all they say that he was a good doctor, okay. And if all they say is a good doctor, it's done. And now he says the last 5 minutes. The last 5 minutes is to do with your career in interventional cardiology. I've told you about the career in interventional cardiology. I think it is huge, but look at the huge way interventional cardiology has given rise to numerous other aspects. And I think you shouldn't lose track of that. Every boy who gets out of medicine wants to be an interventional cardiologist. And after interventional cardiology, they say, now it's done. And we're getting overloaded with interventional cardiologists. Angiograms and PCIs is fine. But I think this whole arena of structural heart therapies, which is the present in the West, which is what we're seeing in India, and which is where you should actually move more and more towards structural heart therapy. Every expensive technique and technology is actually going to become cheaper and cheaper. So the fact that you sit here today and say it's expensive and therefore never going to happen is what you got to look back. 15 years ago, you used to say this for same for angioplasties and stents, and now they're all affordable. Imaging, which was rarely done in the past because of expense, is all affordable. So everything's going to become affordable. That's the sphere you go to. You go into electrophysiology because that adds on a huge arena of treatment of heart failure group of people, which are expanding day after day after day because of MIs and coronary artery disease, and treatment of heart failure, interventional treatment of heart failure, electrophysiological treatment of heart failure is going to become a reality, and don't take your eyes off that. I want the young interventional cardiologists to now diversify into areas of super specialization, which is all needed for Bangladesh. There's this whole arena of peripheral vascular disease. Gain expertise in those things which are not yet available, which are the future for Bangladesh. Pediatric interventions is a need of the hour. Again, something which every interventional cardiologist or pediatric cardiologist needs to start thinking, or pediatrician needs to thinking of going into pediatric cardiology and congenital heart diseases. These are areas which are available for training in India. These are arenas which are available for training in all across the world because there are lesser people going into it, and these are the areas that you need to go. Expand your horizons immensely to see what Bangladesh needs, not today, but in the next 5 years, in the next 10 years, and in the next 15 years. Because your mentors and your leaders who you see sitting around you, who've done great, actually thought of Bangladesh, not on that day. They thought of Bangladesh 5, 10, 15 years later. And that is why you see Bangladesh at the moment leading from the front in interventional cardiology in Asia Pacific and across the world. Is only because they saw 5 and 10 years ahead. I'm giving you the vision for looking at 5, 10 years ahead as the young gen of Bangladesh, saying, where would you want to take Bangladesh in interventional cardiology? You can always ask me more. I know I've exceeded my time. But then it was very important to give you the learnings of my life, which have got me here, which is only to do with one thing. Believe in him, because he gets you there where you are. Give me 2 minutes, 1 minute more. Mohsen, 1 minute more. You're looking at a guy who actually could not get into the medical college for 3 successive years because I couldn't clear the exams of getting into a medical college after my higher secondary. And it was my father who kept insisting that you got to be a doctor. I said, I could do BCom. He said, in those days, he would say, do you want to be a clerk? And I said, clerk? Does BCom always mean a clerk? He insisted. 3 successive years, I couldn't get into a medical. I finally did get into a medical college in an entrance exam, and that was a 7th position in the 2nd waiting list at Jain Medical College, Aligarh Muslim University. I failed every exam in the first professional. I failed every exam. I didn't even qualify. Everybody I spoke to used to say, oh, I topped in my university, that's how I'm here. I actually became, I had the topmost marks in whole of UP. I was number 10th position in whole of UP, that's how I'm here. And what would I say? I couldn't get into this medical college for 3 years. I was nobody. I failed every exam till the first professional happened, and in the first professional, I actually topped anatomy. People came to me in my room, I was sleeping, on the notice board, this get put up, and I was told that you've topped anatomy, and I thought, these are pulling my leg. This is all a joke. I didn't even go and look at it because I was not a person who was ever expected to pass exams. And then I actually went in the evening and saw my name on the top. As the tradition would have it, you had to go to the head of the department the next day to thank him for having topped in a subject. I went to the head of the department next day and said, and he asked me, I didn't sit, he stood at the door, he said, who are you? I said, I'm Ashok Seth. He said, walk in. I walked in. He said, which Ashok Seth? Who Ashok Seth? I said, I actually topped anatomy. And the professor and head of anatomy, what did he say? He asked me, but how did that happen, Dr. Saab? And I was shocked. And I then asked him, but I also came here to ask you, how did that happen, Professor Kumar, his name was. And that day I decided, you will always rise above everything. You will never fail ever again. To succeed, if you fail, to succeed, people would think if you are, then you succeed. People will think either you have, the price you pay for a success is either to do it ever and ever and ever again, or to be ridiculed thereafter. And I didn't want to be ridiculed thereafter. So I think we did it again and again. I would have become a gastroenterologist. I became a cardiologist. I wasn't even going to do interventional cardiology. I became interventional cardiologist. So believe in God. He gets you where you are. It is His methodology to make you believe you are actually just playing your roles in the life that He's created for you and what He wants you to do. Thank you very much.
Thank you, sir.
Mohsin had wanted me to give a talk on step-by-step of TAVI. I gave step-by-step of your lives for yourselves.
Thank you, sir. We can hear you from for whole day long. Thank you, sir. On one last comment from Professor Fazlur Rahman, sir, because our time is very short. Professor A.K. Fazlur Rahman, sir, Chairman of Bangladesh BSU.
Before the comment from Professor Fazlur Rahman, I'd like to take the opportunity for a few seconds. As Dr. Seth, many of us, the interventionalists of Bangladesh, are his fellows, including myself. It's my pleasure. I am grateful to him, and not only I, even he told also the second generation. Yesterday this talk already done, but today in front of this large gallery, I want to tell once again that our younger colleagues are also learning from us, and they are going also to him. Till now, we are learning from him, we have learned from him, and we are working according to his ideology. And today what his ideology he expressed, I hope that all of our interventionalists should follow it, and only then you will succeed in life, not only as an interventionalist, also as a man. Thank you all.